Hey guys, welcome back to Splints and Whiskeys. Sam Patrick here for another episode of our season two, or episode two, season two. Here we go. So on this episode, we're gonna have a very special guest, a good friend of mine that we go back many years now, but also one of the most interesting people I've come across in my experience. So why you're in for a good one. But before we get that into that, let's remind you that Splints and Whiskey is brought to you by Life Autonomous Care Consultants. Again, Life Autonomous Care Consultants, LACCINC.com. Go ahead and check them out. They can hook you up with supplies, training, or anything you might need in the pre-hospital or military medical space. Also, since we are a podcast and we are reliant on the good graces of people taking time out of their day to listen, if you like what you hear, go ahead and like it, subscribe, do whatever we have to do, reshare, retweet, jump up and down in excited fashions while waving signs. I don't care, but do us a solid so we can get the good gospel out there. And if you have anything you'd like to see on the show, please feel free to let us know because we are always trying to grow and adapt to what you guys would like to hear. So enough of that. Without further ado, I have Dr. Timothy Talbot on the line, calling in from Huntsville, Alabama, I believe. A good collection of people we all know down there these days. But Mr. Talbot, or Dr. Talbot, I should say, without further ado, why don't you tell the guests a little bit about yourself?
All right. Well, Sam, thanks for having me on. So it's a little bit of a surprise, but I normally don't talk a lot about myself and what I'm doing. Usually prefer to talk about what everybody else is doing and the good things they're doing. So board certified EMS person. So I've been doing this for 20 plus years. Um, Retired after 28 years in the military, mostly in the soft kind of realm, as you know, and then have gone on to do separate adventures, mostly locums work, and then I also do a lot of remote and austere work, both ends of the Earth, the Arctic, Antarctic, and basically usually on 4 to 5 continents a year,
Yeah.
doing different work. So.
That's awesome. Yeah. So as always, with everybody who likes to come on this show, where everybody's very humble and likes to gloss over the spectacular kind of the resumes we all carry, but that's kind of one of the things that we see consistently across the board is like, yeah, we don't like to talk about ourselves. So to be fair, you can tell other people's stories. We don't have to talk
Mhm.
about you. But there is one thing that I want to focus on first and foremost, just because I think it's super cool, mainly because I'm a dork. But you're one of the few people who can say that they spent the winter in or the Antarctic winter in Antarctica. So tell us a little bit about that.
Yeah, so I was fortunate. I got picked up to work there for the overwinter. Just returned home here at the end of August. So yeah, several right before I got there, the sun went down. So like 2 days before arrival. So we had a little bit of dust for a few weeks, and then we went to dark with no sunlight. And then several days before I left, that's several days after I left, the sun came up.
Yeah,
So yeah, very interesting. The weather, of course, it's in extremes. It can
yeah,
be anything that's beautiful, like -10 and no wind, which is actually gorgeous there,
yeah.
or it can be -74 and 80 knot winds.
Jeez.
Um,
So how many people spend the winter in Antarctica? And
so
is it only at McMurdo, or do they still have other out stations?
no, actually, there's 3 stations for the National Science Foundation currently. So you got Palmer Station, which is up on the peninsula. You have the South Pole Station, which is in the geographic South Pole,
Mhm.
and then McMurdo is the main scientific research station. So of those three, I was actually at McMurdo for the winter. Typically anywhere from 150 to 180, depending on the winter. This year is a little different in that they're doing construction and renewing the base.
Mhm.
So they actually kept over 150 Kiwis on over
Oh,
winter to do internal construction stuff. So it made
nice.
a different dynamic this year with a little bit of a kind of twister, the Kiwi twist to everything.
Right. Yeah.
Um, yeah. So,
Nice.
uh,
Yeah.
but
Go ahead.
yeah. So I basically it's a small clinic, but you're there to take care of everything extreme that happens. Getting in and out in the wintertime. The last flight came in right around mid-March. There were no other flights until mid-August, and
Oh wow.
then a season called Windfly, unless it's a medical emergency.
Yeah,
Uh,
so that being said, I guess so did you have any medical emergencies while you were there that were
yeah, as a matter of fact, in August, we ended up having to bring a flight in, and I ended up coming out on that flight as well, and switching out docks.
okay?
But yeah, so it's unless it's the thing is we have to actually create a landing strip on sea ice. They have a basic pattern set, but then they have to crush it, and pack it in order to land the aircraft.
Oh,
So it usually takes about 48 hours to prep the land for arrival.
right. And that's that's austere medicine at its finest. When you're like, yeah, no, we literally can't. Even, we need to build the airfield. It's going to take us at least 2 days to do that. So that being said, are you the only physician down there, or did you have other docs?
Uh, Correct. Typically, over winter, you'll have one physician over at the South Pole, had a physician in PA, and actually this year we actually had a nurse who happened to be actually married to one of the construction
Oh,
workers, so
nice.
she stayed over the winter because we had a bigger population, which was nice. Critical care nurse, and then Palma Station has a physician. So pretty minimal staffing. So we rely on all the folks that are there. We do have a fire department. We do have a couple. We're lucky this year to actually have two paramedics on the fire department.
Okay.
Not a guarantee. And then we have a search and rescue team as well. But they're all workers and kind of more pre-hospital based.
Right. Yeah. And still you're making the do or making the best with what you have. Do you guys have blood down there, or do you?
So no, we do not. We do have blood draw kits, and we do type and screen folks, and they have to volunteer because it's a civilian entity. We have to volunteer to say, okay, yes, I will be a blood donor,
Mhm.
and they will only do type specific.
Oh, really?
Um, yes, that's their policy. So if we have to activate our walking blood bank, we actually physically call people that have volunteered and say, hey, come into the clinic, which of course gives you a little bit of a slowdown in resuscitation.
Right. Yeah.
Yeah, yeah.
Indeed. Well, I imagine too. I'm guessing the National Science Foundation or whoever manages it, you guys kind of probably do a similar, or I guess, do you guys do a similar medical readiness kind of workup like the military does, where you're making sure you're not sending any zebras to the ice pack?
So it's like going to space. There's
Okay.
actually a pretty significant matter of fact, you have to get a gallbladder ultrasound, make sure you don't have any type of stones.
Nice.
And literally anything dental, which is usually the biggest evacuation issue, has to be solid before you're even allowed to go.
Hmm.
So yeah, you have to go through the UTMB is actually has a medical screening program, and you go through there and have basically head to toe, everything you possibly ever had. And if you skip something, they will bounce you.
Nice.
So yeah, pretty strict on the medical stuff, especially over winter.
Yeah, well, it makes sense because, well, as we know all too well in the military, like what is our health readiness program? It's to mitigate the problems that might pop up because the dental, yeah,
Yeah.
you're spot on. When someone has a toothache, they don't they that will become their biggest problem real quick. Well, that's cool. One thing, yeah. So like the over winter, like for like, what do you guys do on like the psychological aspect of like not seeing the sun for that long?
So very interesting. So I actually taught a class on basically on how to sleep with the
Hmm.
absence of light or with light. So you get both extremes. Summertime is 18 hours of sunlight.
Right.
Wintertime there's zero. So you lose all your social cues and all your visual cues on what's day and night. So you have to be very diligent on setting your schedule and how you do. And of course you get the loneliness. You get small group, and then the stress of work on top of disrupted sleep cycles and all that. So there are a lot of psychological components that go with it. And it's actually one of NASA's analogs for spaceflight. And they
Mm.
look at and do a lot of surveys on the folks there because that's where we're isolated in a box
Yeah.
for 6 months
Right.
almost. So yeah. Um, but yeah, we set up basically have full spectrum light rooms, so people can get kind of a little bit of light, and then try to be very proactive in identifying problems and proactive in identifying conflicts so that they
Hmm.
don't spiral out of control.
Yeah, I think that's
Yeah.
an important aspect is looking at the interpersonal element. That I imagine that the Submariner force and the Navy also probably has very similar programs as especially some of the strategic boats or they go underwater for 3 months with 100 plus of your closest friends and you got to figure it out.
Yeah. Yeah. And there's no space. I mean, at least there we can get outside when the weather's
Right.
adequate and you can take a walk, get away a little bit from everybody. In other spaces, sort of like you said, the submarines, you don't really have a place to take a walk.
Yes.
Um,
You just do some laps around the missile tubes every once in a while. I'm like, hey, this is nice. Oh, this is nice. Yeah, cool. Well, that's an adventure. And then two, I talked to you not too long ago, a few months ago, and you were sailing around the world. Is that correct?
so yeah, I was part of the Clipper Around the World race. So I actually only did two of the legs, but my legs were actually from China, mainland China to Seattle, Seattle down through the Panama Canal up to Washington, D.C.
Cool.
So 8 legs total for the race, goes around the entire year. Matter of fact, they just kicked off and finished the first leg for this year's race. I've been following my old boat
Nice.
online. So yeah.
So, and you were not only were you a crew member, but obviously I take it you were the dock aboard as well. And any good stories come out of the middle of the ocean?
Oh yes, and how many times? So we had the North Pacific, and that gets kind of hairy. How many times the boat was pushed over the side? I've never
Mm,
seen a boat that weighs probably 20 tons going sideways in the water,
mm.
just based on wind force. Um, yeah, I've had a few times, a couple of folks that were knocked off the side of the boat, just not off the boat itself, but knocked over, had a couple concussions, had a couple orthopedic injuries. Thankfully, no burns. So we did have a burn in one of our other boats
Mm.
where you're in the galley, the boat is at 45 to 60 degrees, you're hitting waves, and you're boiling water, which is a recipe for disaster. Um, so
I, I'm not much on physics, but it doesn't seem like the angles marry up there.
oh no, you live anywhere from 45 to 60 degrees for weeks at a time.
Oh wow. Yeah.
So getting in and out of bunks is even a challenge. If you're on the upside, you're climbing walls to get in your bunk. If you're on the downside, it's getting out of the bunk, which is the issue.
Yeah.
And there's no showers, and you only have two heads, and yeah. So and it's
Yeah.
24 hours a day because the boat never stops.
I mean, like, I look at all these things you're doing. It's like you didn't get enough misery in the army. I guess we failed you. We could have made you like sleep outside a little bit more. My bad. Yeah,
Well,
yeah.
funny enough, I started as an infantryman, so I got plenty of outdoor time.
I mean, I guess if you know what you stick with it. Actually, it's funny because I talked with a buddy of mine. He's a former Ranger and then became a SF major. He's like, they were doing a manhunt up here recently. He's like, saw him a couple days ago. Yeah, he's like, I just tested out to be a captain because I realized as I was walking through the woods on this manhunt with a rifle, I've been doing this since I was 18. I was like, yeah, yeah, yeah.
Yep.
Sometimes we just get uncomfortable in the suck. So one thing too, you did your EMS fellowship, correct?
No, actually, I was one of the ones that challenged the first test.
Oh,
Actually,
nice.
the 15% that passed the first test the
Oh,
first time around.
so you're the beta tester. So
I
nice.
I am the hands-on guy. I actually came up through the hands-on aspect of it.
Right on.
So
So
yeah.
you started your career as an infantryman. You just said that, right? And then
Mhm.
what did you go from like how did you jump from army infantryman to physician?
Actually, so part of that was because I was down in Panama. We were somewhat geographically dislocated from everybody else.
Hmm.
We were very short on medics all the time. So as a squad leader, a lot of times I would not have a medic out with us. So I was a little concerned about my guys, and I'm just like, okay, teach me something. Teach me how to take care of my guys when you aren't around. Um, so we had a couple of incidents, and one guy heat stroke. We ended up having to make an LZ and stabilize him and get him out. And I realized I enjoyed that. I
Hmm.
actually enjoyed taking care of someone, seeing a good end result come out of it. So that kind of pushed me to start doing more classes, and then decided to go back to school and figure out whether or not would be a good medical route to go. So.
Nice. Did you do med school through the military then, or did you do it outside?
Yes, the Uniform Services University. So I went back, did my undergraduate. I actually did 2 degrees in 3 years, and then a little more focused. This was my second time at college. My first time didn't work out so well, but a little more focused in the second time around. And then yeah, the uses, and then it was history from there.
Right. And did so you obviously went the emergency medicine route, and then after did you come right into the community or the soft community after residency or
So our pathways were a little different back then. You had to pay your dues. You had to go out do an operational assignment,
okay.
and then you might get choice of residency instead of going straight to residency. So we had a kind of a different pathway. Everybody had to pay their dues, go out for 2 to 3 years, and then come back.
Okay.
So I actually ended up going straight out of internship to 3rd Battalion,
Oh really?
160th.
Okay.
Yeah. So at the same time, a couple of the other older guys that I went through uses with, played rugby with, were the docks for 1st and 2nd Battalion. So I kind of got recruited early to go there.
Nice.
Um, and then I left 3rd Battalion to go to my residency, then came back, back to regiment, and then back to 4th Battalion, and back to regiment again. So yeah,
Right on. Well,
yeah.
and the regiment we are talking about is the 160th Special Operations Aviation Regiment. So that's where I met Dr. Talbot many moons ago when I was a young baby flight medic. And actually, you were one of the plank holders up at 4160, correct?
That is correct. Yeah, I
Yeah.
actually said I was there for the very actually one of the first three folks actually assigned
Oh,
back at Campbell,
okay.
and then we finally moved everything and got everything set up there. Yeah.
Very cool. Yeah, no, we just had our 20th year anniversary, so we saw a bunch of the familiar faces there. And so you've actually because you were in third. Well, when were you in 3160?
97 at 2000.
Okay, so you were have
Um,
been inside of the belly of the beast, like through the transition from what we were used to be doing, and then watching TC like tactical combat casualty care evolve to what it is today. Um,
mm,
so
that would be correct. And it's funny enough, it was during that first few years of GWAT, um, all the doctors that were in every special operations position and billet across Army, Navy, and Air Force, everybody were all graduates of the uniformed services, and we'd all played rugby together. So we knew each other, which helped out tremendously in fixing problems
right,
because you could pick up the phone and call because you knew who was on the other end, and you
yeah,
know that they would listen. Yeah.
that's awesome. Yeah, it's interesting, kind of like to see. Well, because I my first deployment was 2006, 2007, and like we had on the conventional side of things, we started to see the shift to TC3. There's a little bit of emphasis, but like, w- so I know the Frank Butler paper came out in '96. Is that correct?
I believe so. Yeah.
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 So the paper that basically was the origin story of TC3 comes out in '96. You're inside or as close to that community as possible because well, the Rangers have a element in Savannah as well.
Mhm.
What did you see at the unit level? Like, what was that adopted pretty quickly, or like kind of was there like a hesitation, or I guess kind of like what did it look like back then when that idea first came to fruition?
Yeah, so that was it's actually very interesting to watch the transition because everybody was kind of watching that. We're
Mhm.
like, okay, and good thing that it went to the Ranger Regiment to start the process because they're very directive,
Right.
and
Yes.
they just like, okay, we're going to make this happen. Yeah, and they had some really exceptional leaders at the time. You had Monty there, you had Russ Cotwall. I mean, I can't remember all the names, but
Right.
you said very very driven people that said, okay, this is what we need to do to make it better. Even our early days in the 160th, the medics didn't fly.
Right.
The medics were actually clinic-based medics until we get to the point where we realize, hey, our customer needs somebody to hand off to,
Right.
right? And someone has to be of equivalent training. So then we had to develop a program to kind of match what the 75th was doing,
Right.
and then everybody else.
Because
Um,
what year did we start seeing actual like operational flight medics in the 160th? I can't remember.
Oh, I'm gonna tell you, that's a hard one because that would have been right around the time that I'd gotten to Savannah. That was really the early infancy. It's within the first 1 or 2 years of that. So it was probably right around 95, 96.
Right.
And they actually got allowed them to be on the aircraft rather than just, going with them somewhere. They were
Yeah.
actually on the aircraft acting as medics.
Nice. Yeah. That's I always I always forget that you're the one of the people to watch that actually happen, and it's kind of
Mm.
cool to see the progression that we've gone to now with the medic being so integral into so many of the things, and then also to just like the relationship that we've had with the Ranger Regiment and the 160th throughout time. Um, well, and since you were at that ground level, though, so what did you see as kind of a shift in training when we realized, hey, kind of the old model of the field dressing on the LCE wasn't the right way to go?
Mhm. I think that's when we started doing the dry fiber and bandages. A lot of the stuff that came out of Bragg, which drove a lot of the innovation, because a lot of folks weren't happy with what they were taught in basic training in AIT, and like this is not working. It's not working for what we're seeing. It's not working on taking care of casualties. And I think at the same time you had that whole kind of push with the hypotensive resuscitation with Butler and the rest of the group, where they said, okay, this doesn't work for the combat environment. This is great for the civilian world where you have
Right.
all the resources. It does not work for the combat environment. I think it was just a beautiful kind of juxtaposition where everything kind of came together at the same time. Paper came out. 75th started looking at their program and says, hey, this is not, they got the right people in at the right time. And they said, this is not good for us. And when they adopted that as a leadership program and not a medical program, that was the big kicker. And then the rest of the units kind of followed after that.
I'm glad you brought that up because that is uh, the leadership aspect that the Rangers brought to casualty response. I think they still have the casualty response course for leaders in the Ranger Regiment.
Mhm.
Um, I think that's truly when we talk about organizations, not just military, like organizations that are serious about casualty response, make it a leadership priority. Um, and you're still involved heavily in lots of regions, like the Antarctic mission, like all this stuff. How often outside of kind of like because we know the organizations we were talking about, the 160th, the Ranger
Mhm.
Regiment, some of the special mission units, they get it. On
Mhm.
some of your jobs you're doing right now or other activities, like how what's the level of buy-in for people understanding that the casualty response or the sick patient response is a whole of team thing as opposed to just a medical problem?
Still hit or miss, um, depending on where you're at. So I do have a chance to work with some conventional units in some of the jobs that I do, who provide security and or manning for some of the areas we're in. Um, it's very hit or miss. You see, it's all very dependent, leader dependent on who the senior NCO is there for the most part, and whether or not they take it seriously and whether the command actually buys into what they say. Um, I've had one instance where, we usually take our security force and incorporate that into all of our casualty play because they're the first ones going to see it. It's
Hmm.
the buddy aid, carrying a fire, um, and then it's movement to us. Um, we've had some beautiful ones where their senior NCO was invested and said,
Okay.
okay, teach me as much as I can know, teach my guys as much as I can know. And then we got to the point where even the mortar platoon was doing casualty drills without a medic present.
I think
Um, yeah.
that's the importance is, and one of the things I always emphasize, like especially a lot of the work I'm doing in the civil space with law enforcement and fire, like the most important person in the chain of survival is that person who puts their hands on that individual
Mhm.
immediately. Um,
Yeah.
and I think that's one thing I've always tried to emphasize to the lay rescuers. Like, no, like you don't need a lot of knowledge. You need to know what to do if you see something that's significantly bad and stopgap it. Because if you do that right, it makes my job easier. It makes your job easier, and ultimately, it makes that hospitalist who has to clean up all of the messes we made a little bit easier.
Yeah. And that's the one thing I stress consistently with a lot of folks that we work with is my current position is working on a mobile surgical team
Hmm.
with one company I work for. Um, we can't do anything with a casualty without what you have done pre-hospital and what you have done at the point of wounding and make them survive. You
Yes.
give us the time, you buy us the time to provide that surgical intervention, but without that pre-hospital piece, that very important pre-hospital piece, nothing happens with that casualty beyond arrival. So
Yes. Yeah,
yeah.
and I think that's another when I do like analysis of systems and stuff. Like
Mhm.
I'm a very time driven person. Like, all right, where are the efficiencies in time, or where are the inefficiencies of time, and how can we mitigate that? Because even you look at your mission down in Antarctica, like okay, we know we have a 48-hour window to get someone off the rock if we have to.
Mhm.
Because even something as simple as delaying a phone call for 30 minutes could be the make or break difference between whatever tail was supposed to come to you is now unavailable and they're scrambling to get another airplane since I could try to use
Yeah. And then
layman's
it
terms.
has to be specialty crews, specialty aircraft. So if those are unavailable, I mean, that's all you got. But it's very interesting to see. When I first got down there, we did a lot of rehearsals and training. I went to our team lead. I went to our fire department. I'm like, okay, we can't be stovepiped here. I need you guys. It's just me, the PA, and the nurse, right? We got three people. We're done.
Right.
And the chance of it being something like that, a roll of advantage for Kavas, something catastrophic in one of the workspaces, we need all the bodies that are here. So what we have to be able to do is work together efficiently and make that chain better, um, which they had not done for a while. So
Really?
by the time end of the summer, we actually had pretty good mass casualty group in place, and everything was efficient. We identified a lot of problems by actually doing hands-on rehearsals with victims, which I hadn't done in a while. Um, and then we continually trained every week. It wasn't as simple of we do a mass casualty drill, we're done for the season,
Right.
everybody have a good time. So I think that's probably one of the key things, continuing those rehearsals, continuing mastering the basics, and working through those friction points and identifying those problems because you don't know until you put your hands on and you realize that piece of equipment is not there.
Right. Yes, 100%.
Yeah,
And
yeah,
or that this choke point or this friction point, oh, we didn't see that until we actually tried to put people through the system. And
yeah.
that's I'm glad it's such a valid point because you look at so much of what we try to replicate when we try to replicate the chaos of an actual incident in
Mhm.
training, it's hard because it
Yeah.
takes to build a good, realistic, like high fidelity training simulation. Like it's a lot of work. And quite frankly, like I just I helped Seattle Police run the law enforcement and casualty care course, and I realized that we had an instructor to student ratio of almost 1 to 2 when it came down
Mhm.
to like instructors were role players. They there were various layers, but like regardless, there was
Mhm.
knowledgeable people, and like that is kind of, in my opinion, like I know we have a 1 to 6 ratio minimum in the TC3 world for training, but like getting that 1 to 1 or 1 to 2 provides everybody to have that actual oversight on all the little things we're doing. Because as you've seen through military
Mhm.
training and then training across the board, how hard is it to set up realistic training for your people and validate it, but also then realize like, hey, I have to be part of this training too because if this actually happens, I'm going to be involved.
It's difficult when you're the only one. Very difficult. It's a little easier, as like I said, in the mobile surgical team realm where I'm working, where we have external players and external units we're supporting, so we can bring other folks in to actually give me feedback as well, right?
Hmm.
But also give us some external feedback. A lot of times when we do the training, we're like, we've done the training of us patting each other on the back. It's just like, well, wait a minute, you're patting yourself on the back, but did you see what just happened over here?
Right.
Right. So you need that realistic feedback. You got to, and like we grew up in, you got to have a thick skin. You got to have that realistic feedback and realize, you don't know everything.
Yeah.
And everybody else in there can see something a little bit differently that we made to make better the next time.
Yeah. No,
So,
and I think that's one of the things that we struggle with in the community, or not the community, just like as humans in general, we have a hard time letting our guard down to actually genuinely focus on what we can improve on. Like for when you're running these trainings and you're trying these AERs, what are some of the techniques that you use to kind of like, hey guys, like let's focus on what we can do better for the person having the worst day of their life.
mhm. Part of that is make sure you have the preparation, right? You have a good script. You have someone that's going to OC it, but you give them a couple latitudes of, okay, the vital signs, did this intervention, vital signs changed. It shouldn't be just a one-stop thing. It's like, okay, here's their initial vital signs, go. It's like, okay, you made an intervention. Okay, here's new vital signs here, and make them more of a thinking type training, not just a reactive and going through the rote
Right.
steps. Right now, they have to react to new vital signs. Now they have to react to new data and how the patient's doing. So we tried to make these more dynamic, so that they're constantly getting new inputs and changes in their patient, scenario. So they have to think through the process of what they're doing and reassess and
Hmm.
reconfigure what they were doing. So
Right. Very cool.
yeah.
I like that. Just talking about kind of the disarmament in AARs there. So another thing too that I struggle with when I'm building training iterations is level of complexity and the simulations we have available. How often are you finding like you're like running into hurdles just because like okay, I'm trying to replicate this complex thing, but I'm not able to give people the realistic feedback that would really be value added for training.
That's it's always a problem, right? How do we make it so it feels like you're actually under that? So it's going to have to be some type of changing the environment around him, noise, night, day, distractors, flashbangs, or even just radio noises or something that sounds like combat. Um, so providing that right environment, the environmental sounds and distractors so they can actually do good. Um, yeah, that's hard doing it. So this last time around, we actually had, like I said, very, very good Sec 4 unit for this last rotation I was on. So we had a very variety of EMT basics, 18, a couple of 18 series guys. So we had to change the training so that each one of them got a piece of the training to the complexity of what they've been taught.
Hmm.
So we incorporated some of the additive manufacturing stuff, making a trachea so we could actually do, crikes. So we used some of those. We actually made some of our own kind of chest tube simulator type things. So when they said, "Hey, I would do this," we throw it down and say, "Here, do it." Right? There's not none of this. I can say I can do this. Is now go through the motions, build that muscle memory, and actually do the procedure.
Right.
Um, so you kind of got to get down to high fidelity training, where you can actually do that. And I think it's a little easier now because we can recreate some of those kind of training aids. But still, there's nothing like the real situation, right?
Right.
Because you still don't get that same rise and the adrenaline. You still don't get that cortisol release. You're not fully clamped down and kind of narrow focus. I mean, you do the best you can, right, to
Yeah.
make that situation a little bit more. But and we've incorporated for most of our Sec 4 guys, we actually started drawing blood and having them do blood in the field,
Oh, nice.
which was well beyond their normal things they were allowed to do with their unit. But their command was bought in. They bought in big time and said, okay, you train them. If they're competent to do it, you do it.
Nice.
Yeah.
Yeah, well, that's one of those things too. Is like you look at the Ranger model, the Ranger first responder. They're the ones who are initiating the blood draws for the field blood transfusions and all that as
Mhm.
well. So it's well with it's possible to teach it, but also um, it's and it's just articulating the why behind it.
Mhm.
For your guys' the surgical teams you're working with, like how long are you expected to hold patients for?
Yeah, so we really don't have a holding capacity.
Right.
So once we get two patients, we're done. It's
Hmm.
only a 5-man team. So we're made to be the quick hit and then get them out. We're very dependent on the folks we work with. If we want to hold someone for a period of time, most that we really want to hold for is 24 hours.
Hmm.
Um, but depending on airflow and location, it may be longer. We're
Right.
pretty, we're pretty good. We can hold folks for quite a long time, usually up to 72, maybe longer, depending on the situation. Plenty of supplies to do that. It's just a matter of we now can't take care of any new casualties.
Right.
Yeah.
Yeah, and I think that's always one of those things too that we look at military medicine, especially when we start looking at prolonged field care or prolonged
Mhm.
casualty care or delayed evacuation casualty care, whatever the brand of the week
Mhm.
is. Like we still forget that no, not forget. It's the wrong term. It's like what I see is a lot of commanders get or people who are in charge of making decisions get this idea that no, this element can hold this sick person for X amount of times. Like no, if they need evac, we still need to get them out and gone. Like holding them is something we can do, but it should never be that priority. Um, if you see, like, since you guys run a relatively smaller team, if you had to hold that patient for 72 hours, are you seeing that you need to bring in, say, some of those the cross-trained security forces guys or somebody else to essentially just like for the work rest cycle of having to manage someone that long?
We typically will, and typically we'll utilize some of the higher level providers that are out there to put them into the rotation. But with 5 of us, it's usually pretty robust. I mean, you can just take 2 4-hour shifts and
Hmm.
and you can kind of handle it.
Right.
But yeah, I mean, for 1 or 2 casualties, it's not so bad with a smaller unit. But we always rely on other folks to bring anybody medical. We bring them in to help let you get some rest eventually.
Yeah,
Yeah,
yeah, yeah. And also you can get some experience and realize that
yeah,
some of this stuff isn't as hard as we like to make it seem like sometimes. It's simple things do simple things go a long way, especially when
yeah.
it comes to comfort and nursing care, that's for sure.
Mhm.
Are you still doing are you only doing kind of work overseas? Or are you still doing shifts at
Oh no, I'm still active full-time here a physician.
okay,
So when I'm home, um, so typically every couple of months I'll be home and I'll work for a couple of months and then head out again. So
nice.
yeah.
And so how some of since you have the very broad scope of austere medicine, like um how are you able to kind of pay that, or what are you working on any kind of projects to take those lessons learned and bring them to kind of like the civil hospital that you're working in, or hosting chats or whatever?
Mm. So I typically would, usually the paramedics that I'm involved with whichever systems I'm in. But typically, we talk a little bit about cases that they bring in, if
Mhm.
there's any traumatic stuff, and what, if they could have done anything better. So it's usually, instantaneous feedback or, congratulations, you guys did a great job and thank you for giving me someone I can actually save.
Right.
Yeah. But I also do a lot of work. So there's a group out of the HMJ Foundation. So Ian Wedmore and his group that are
Mhm.
doing the dive and marine medicine and the mountain medicine course up
Mhm.
in Jericho. So we incorporate a lot of that information into training the new med students, nurse practitioners, PAs, and various folks from other elements that come to those courses. So we do a lot of teaching in that respect.
Nice. And that's those are those military specific courses, or are they kind of, or do they have civilian reach as well?
Military specific, they're funded out of the DHA's kind of
Okay.
budget. Yeah. But yeah, I mean, there were other folks that kind of audit the course on occasion,
Hmm.
just for the fun of it and then to kind of learn something new.
Yeah, no, it's like I look at all of our subspecialties we have in medicine, and what I always say is like, oh, the common denominator is that last word. It's just medicine. We,
Mhm.
we just try to do the best we can in the environments we have. Because I deal with this in certain elements of the world where I just had a discussion about the impact of certain journals and stuff like that, and it makes me like, well, not everything can be measured by an impact statement. When if you're such a niche specialty, it's like, all right, how do we consolidate all of kind of these niche little things and realize like, oh no, there's common threads amongst all of them, because austere medicine and military medicine often go hand in hand, and we can't always replicate everything. um, One thing that I have learned through kind of some of my teaching is we in medicine do seem to do a very good job at making things seem more complicated than they are sometimes, especially when it comes to communicating to like one of the reasons why I think like, hey doc, you good in the medical world or the military world, is because they just don't understand what we do. Is like, do you think we do in medicine a disservice by maybe not helping those who are not in medicine understand what they can do to help solve the wicked problems we look at?
I do, because with that not having an understanding of what we're doing, they don't understand the requirements, they don't understand the equipment needed, they don't understand the costs, and they also don't understand the outcomes, which is the thing, because most people today live on what they see on TV and the magic, right?
Hmm.
Right, this guy's going to get up and walk away afterwards. It's like that is not the case. In most situations, there's a long road ahead for several years before they're up and walking out of that hospital again.
Right.
Um, so I think we do a very much a disservice in that respect by not educating them enough. And that's one of those things that I like to do in the part of the training piece is to get one or two of those leaders there and make sure that they understand what we're doing, what their people are doing, and why they need what they have and why they need the training they have.
Right.
So yeah.
Yeah, that's you mentioned the downstream effects is what I like to call them, and
Mhm.
that's one thing that took me a while as a medic to come to appreciate. It's like, oh, I didn't really count getting casualties to the first level of care as a win. It's like, how fast can we get them out of the the inpatient facility or the special nursing facility that they end up in. Um,
Mhm.
so with that being said, in some of the civil work, civilian work you're doing, are you seeing kind of that emphasis placed on the pre-hospital provider? Like, hey, if you make the right, if you like, the quality of life emphasis of making the right choice in the field.
Mm. So it's interesting to watch. Some systems are just they really could care less. You got them at the hospital, okay, everything's great now. Some systems are really high fidelity systems. They go back and go from they want to know when the patient get discharged, downstream is like you said, the downstream effects of what happened based on their initial results, and their medical directors are feeding that directly back into their training
Mm.
programs. So all again, very much people dependent and system dependent on how much of that goes back and retrains the folks or graduates them. Yes, this training you did and you retained this and you did this, it worked, right?
Yeah.
And that's the hard part about our job. Sometimes you lose that connection between what goes on in the hospital and after the hospital to what happens in the pre-hospital space.
And that to me, like, I look at the military model. The military model, is it perfect? Absolutely not. But like between the joint trauma system, the lessons learned entities we have, we do a pretty good ability to go back in time and see where we can have improvements. But where it's very kind of just, not disheartening is the wrong term. It's like, I guess, assumptions being made by people, like especially if you work in a federal entity and think everything is supposed to work somewhat uniformly. When you get into the civil space and realize, like, no, we're a hodgepodge of, like, it purely is based off if a medical director cares enough to do case reviews with their medics. That's sometimes it.
Mhm. Yeah, and that's absolutely correct. It depends on the personality that's in there at the time, um, for a lot of places. And those may not be folks that actually have ever been in the pre-hospital space themselves.
Right.
That may be some random doctor who just signing up on their charts.
And that's yeah, just in the state of Washington alone, when I learned about the EMS fiefdoms and hierarchies here, I was like, oh, this does not seem to be very efficient, but okay, we'll
Mhm.
give it a shot. Um,
Mhm.
I guess that being said, so like since we do get a lot of EMS providers, you'll get EMTs or even non-medical people and paramedics. It's like, what can they do to get kind of that, like, that true medical direction? Like if they're not getting it from somebody, like what are some of the techniques that, or potential avenues they could approach to kind of like, hey, can we get a little bit more on how this case went?
Yeah, so that's hard, because then you get into the whole HIPAA unless you're a covered entity and you have
Right.
agreements in place, which are not insurmountable. It's just a little paperwork you got to do, but you got to have someone who's willing to take that chore on. Um, yeah, so it all depends on who's funding them, where they're based. Are they third service based? Are they fire department based? Are they hospital based? Um, and the ease of and the relationship between the two that allows them to get that information flow can become bi-directional information flow instead of just a solid wall. Once they hit the door, we don't know anything about that patient ever again. Um, a lot of challenges in that respect across the entire system,
Right. Yeah.
because there's so much fragmentation. Some are county-based payments. Some are just their hospital pays for them, but they see them as a loss because we're paying all this money for these people and they don't really do anything.
Hmm.
But then again, that's where the ignorance factor comes in too. So
Yeah,
yeah,
it's a convoluted one, the
yeah,
EMS space. That's for sure.
yeah,
um,
entirely too convoluted.
yeah,
Um,
I think we just real the last interview I did about the blood, and we're looking at only
mhm,
about 2% of EMS agencies have field blood yet. But that's still better than it was 10 years ago. That's for sure.
that's
Um,
absolutely true. Yeah.
are any of your agencies around you carrying blood in the field yet?
I do believe Huntsville Hospital System here does.
Okay,
Yeah,
nice,
they've started a HEMC. Actually, yeah, HEMC does. So
cool.
yeah.
Yeah, it seems it's taking traction and getting hold.
Mhm.
Because as we've seen with early access to defibrillation, for the patient that
Mhm.
needs resuscitation, they need resuscitation. There's no
Yeah.
argument about that. Actually, I would like to pick your brain on this. So, the resuscitate before intubate discussion
Uh,
that is going on. What are your thoughts
mhm.
on that?
I am a fully behind the resuscitate before intubation. Um, Over my career, I've seen so many times where we've had the patient essentially crash once we put them down,
Hmm.
and in combat and in civilian world,
Right.
where we've seen the patient basically lose all vital signs, asystolic, and have then now we get twice the work of trying to get them back.
Right.
Um, I think we can maintain the airway well without having to intubate for the most part, right? Even if we have to cut the neck, we still have a working airway.
Right.
Um, and then once we get them resuscitated enough that we can actually do something else, the intubation part, um, I think is one of the things we really need to make sure we focus on before we intubate folks is are able to be intubated, or are we going to have that post resuscitation crash? So,
Right. Which for those that I quickly go down the advanced provider route and I realize, okay, well, I should explain some terms real quick. So intubate, when we take someone's airway by paralyzing them and giving them heavy doses of sedation and then taking a metal blade or something similar to put a plastic tube down their throat. And as you can sound, that sounds pretty bad. So yeah, your body doesn't like it very much. And then the argument that is to be made, the resuscitate before intubate is, before we do all that to somebody, let's make sure that their pump is operating the best it can, that their fluid level is the correct one, and we're not gonna send them down a rabbit hole just because we have some indications that we can do this field procedure
yeah,
that may not be indicated.
yeah. And you're taking away that that adrenaline response, which is adrenaline is one of your best pressors.
Yes.
Um, so yeah.
And that's one thing too that I emphasize on with the whole time aspect, and like obviously resuscitating gets you can buy yourself some more time as
Mm,
well. Um, so one of the planning tools that I've been using recently is not so much time to surgery, but like I look at, for kind of austere work or tactical EMS work, time to aggressive resuscitation is something I work in there just as much as time to surgery. What are your thoughts on that kind of planning factor?
you know, most folks, once you resuscitate them, a lot of them don't require surgery,
Hmm.
right? They just need a resuscitation. They need to replace whatever they've lost. Um, so I think that's a pretty good kind of timeline indicator. You can say, okay, how long did it take for us to get the blood on board? How long
Right.
did it take for us to open the airway and make sure they're ventilating? How long did it take us to stop the bleeding for the first part, right? So as part of that resuscitation, um, I think that's a pretty good marker to say, okay, how long do we get them to they actually had a set of stable vital signs? I mean, they said only a small percentage of them are going to go to surgery.
Right.
The rest of them, simple resuscitation is enough.
Yeah. And I think that's an important element because you said it yourself, like when we're looking at acute trauma patients, stopping
Mm,
the bleed is the first step in resuscitation, just like high quality compression only CPR has also been shown to work well for the initial stopgapping of cardiac arrest.
mm,
Um, I, I guess for in your practice, and you've seen this progression. You've seen the progression
mm,
from where we basically just did tourniquet was a last resort. We did elevation of the limb beforehand, and then we're also resuscitating heavily with clear
yeah,
fluids.
let's start the IV first before we start talking about stopping the bleeding.
Right.
Yes, yeah, I've seen that entire progression because that was the basic medic when I first started in the army. It
Hmm.
was, let's get that IV started. All right.
Right.
What about the guys bleeding out? Yeah.
So that's a question I have for you too. So I've seen this. And it's kind of it's a loose joke, but like I'll walk into a
Mm,
like when I walk into a trauma bay in the hospital and I see blood on the floor, I'm like, all right, this looks like a bit of a sloppy resuscitation went on here because all right, if they had blood coming out on the floor, who was focusing on stopping that? Because like my anecdotal
mm.
observation is when you work in a place that you can just put the fluid back into them that you've let fall on the floor, you develop some sloppy habits. Um, do you think there's a spillover kind of from that into the field? Because I've seen this time and time again where when people are working on a tool, they don't do the initial stopgap just to prevent the leak from happening.
Mm. Um, I think we've hammered people enough now that they're very cognizant of the fact that, hey, I need to stop, and I may not need blood if I stop it before it ends up on the floor or on the
Good.
ground. So I think we've hammered people enough now that they're actually starting to realize that, hey, I can save myself a lot of work on the other end by doing a simple thing and stopping that bleeding.
Good. Yeah,
Yeah.
and that's one thing I've also noticed too is we are trending back to like, hey, Because even back in the day, when you look at the initial ATLS guidelines for bleeding control, it was direct pressure, pressure point, elevation, and then tourniquet. And everybody was like, "Oh, it's because tourniquets are dangerous." And in my opinion, I always thought, I was like, "No, it's because like, hey, tourniquets take a little bit more time than all these other things. Do these first while you're getting your tourniquet out."
Mhm.
So
Yeah. So it's interesting to see. We're also seeing a kind of a swing back now with the Ukrainian experience on the tourniquets, right? Because you're seeing people that have them on 6, 8, 12, 24, 36 hours. So of course you're gonna have limb salvage problems. You're gonna have all sorts of secondary effects. We were lucky in that our respective most of the part of our wars, we were able to get folks within several hours, and that tourniquet came down.
right.
But now it's a whole different ballpark with what we're looking for the future.
And again, this is not a Dr. Talbot's opinion
Mm.
or guidance on medicine here. I'm going to ask Tim Talbot's opinion from your lifelong experience in your community of what level should we start having people think about like and not like level. I mean, I guess what practitioner level should we start having people really starting to think about tourniquet conversion?
I don't think it's that hard to actually teach. From just again, my personal opinion,
Mm-hmm.
um, I can teach someone to say, okay, I've put a hemostatic in, I put a real good pressure dressing on it. I'm starting to take it down. I'm getting some pulse flow back. Am I seeing bleeding? Right? That's actually a pretty simple thing. It's trying to recognize those hidden bleeds, right? Are they filling up a compartment in that limb that you don't see coming externally? That's a little bit more nuanced.
Mm-hmm.
And that may require someone, kind of almost like a paramedic level or something that has a little bit more physiology knowledge
Right.
and a little bit more anatomy knowledge that they can recognize that, okay, there's something wrong here, right? Continued rebleeding, pressure's not holding, um, more focus on that. I think, I mean, we can teach someone basic stuff on doing that for most limb stuff. But when you start talking bigger compartments, more proximals, I think that's going to be more tricky to kind of teach.
Yeah, no, that's fair. I've always said to people because you definitely are seeing tourniquet happy application across the board,
Mm,
which I'm my opinion, like, hey, yeah, you're never wrong applying a tourniquet, but you should also be immediately assessing, do I really need this? And yes, there are some sites we should be concerned about, but
mm,
also if it doesn't look like it needs a tourniquet, it doesn't hurt to try it without it. I'm just,
mhm.
that's my opinion.
Yeah. And I think I've seen it as a lot of folks, um, this whole process of you put the tourniquet on and never take it off, because that's above my training level. It's like, well, sometimes we use it as a temporizing measure. I don't have enough hands to take care of all the same problems, right?
Hmm.
I only have my two hands, and if I can throw a tourniquet on there, now I have my two hands back to work on the airway, to work on anything else that's going on. Um, I kind of look at the tourniquet as a temporizing measure. Can I get that bleeding controlled in some other fashion? Can I get them resuscitated? And then it's coming off.
Yeah.
Yeah.
No, I like hearing that because I've gotten to the same point now where like, hey, if I this is a shutoff valve. All right, I've applied
Mm,
my shutoff valve. Like ultimately, what I want to do is get my plumbing to work as close to
mm,
normal again as possible. So I'm going to have to turn the valve back on eventually,
yeah.
and that's another thing too. We tend to not discount. It's like no, there's plenty of other sympathetic flows for your blood to go that can help salvage that limb in real time versus having to wait for ortho or vascular to come and do it for you.
Mm,
So
yeah. And I think it's a skill that can be taught. We just have to be very judicious on who we're teaching it to and make sure they have the adequate, like I said, physiological and anatomical knowledge to identify the hidden stuff.
yes, yes, and
Yeah.
that's the hard one where we
Yeah.
definitely getting and you work in the EMS space. It's getting those providers, the pre-hospital providers who, oh, I've only got a 15-minute transport time. Like I don't have to worry about this stuff. It's like, no, well,
Mhm.
let's not every day is going to be a 15-minute transport. Or if you are a paramedic level practitioner with that mentality, I personally encourage you to seek deeper knowledge behind what's going on because hey,
Mm.
weird things happen.
Yes.
Yeah,
Yeah.
this
And sometimes you're there a lot longer than you think you're going to be.
right. Yeah,
So, yeah.
for instance, we had traditional 15-minute evac times in Seattle go to 6 hours one time because of a certain event that was occurring. So like, yeah,
Mhm.
don't always assume your operational environment is going to be rainbows and gumdrops. Yeah, words.
Mhm.
Well, sir, we are approaching the mythical time of an hour, which is what we like to keep this to run time to. So we've
Mhm.
we've obviously gone down some fun little journeys and rabbit holes here. Would you like to have any closing comments that you'd like to impart on the next generation that's going to be following us in our footsteps?
Yeah. Um, my hat's off to you because this is going to be now we've gone away from the golden hour and our ability to get someone to help within a couple hours to a surgical team. It becomes much more complex when you start looking at the Pacific, you start looking at the Arctic environment. Our world just got bigger and more complex with many more factors that are involved. But when it comes down to it, you got to know the basics, period. Right? If you master the basics, you rehearse with everybody you're working with, you're going to do fine, regardless of the environment you're in. Um, and I always going to tell folks is there are a lot of folks that get into this whole thing. I do what I learned, and 15 years later, I do what I learned. Be a continuous learner. Learn all the time because medicine changes so quickly and the environment changes so quickly. So it's kind of the two things that I kind of harp with my folks. It's like you gotta continue to learn
Yes.
because it's always changing.
Awesome. Oh, I love that. And again, Doc, thanks again for coming on. Again, I also appreciate the mentorship you provided to me when I was a young lad many years ago, and then too like all that you're continuing to do to advance everything that is emergency medicine and military medicine. And it's cool to talk to somebody who was there when all of the things that we are currently riding the coattails of were starting to happen, and you were instrumental in helping implement. So again, I thank you for everything you've done and continue to do, and I look forward to hearing what adventures you've been on next, and get slightly green with envy that I want to go do that. That sounds fun. Um, but hey,
Well,
stick around after this when we cut out. I just got to do the quick closeout here. But again, thanks for listening to Splints and Whiskeys, Splints and Whiskey. If you like what you heard today, go ahead and give us a like or subscribe, whatever you want. Again, Dr. Talbot, ER physician for forever, and a world traveler, bringing the greater good to everywhere he goes. Again. Splints and Whiskey is brought to you by laccinc.com. Check them out. And thanks again, Doc. We'll talk to you soon.
yeah, thanks. Appreciate it, Sam.